Thanks for being here tonight. And I do want to say that while the talk is entitled Neck and Back Pain in Women, I do see some men here, which is great, because pretty much everything I'm talking about also applies to men. Yeah, you have the same thing, and pretty much everything applies. There are just a couple things where it's true that we see these diseases more in women, and so I'll touch upon that, but everything is still useful for you as well. So, as I'm sure everyone here knows, lower back pain is incredibly common. 90% of adults will experience lower back pain at some point over their lifetime, and it's a major cause of disability for people who are over the age of 40. The good news is that only a smaller percentage of people will really have chronic back pain, so 10 to 20% of people. And the cost due to lost hours at work is over $50 billion. So we know this is a huge problem. It's one of the most common things that primary care doctors see. And I'm sure that every single one of you has either had back or neck pain at some point in your life or known someone very close to you who has had it. And so the first question is, when you have an acute episode of back pain, your back gives out, what do you do? So first of all, don't panic. Okay, this, as I said, it's extremely common. Everyone will experience this some point in their lifetime. Apply heat. Try a non-steroidal anti-inflammatory medication. So those include Motrin, Aleve, ibuprofen, naproxen. Those are really good at fighting the inflammation that is the cause of a lot of this pain. You can also take over-counter Tylenol. You can try a hot shower or gentle stretching. The majority of chronic back pain is really sort of diffuse musculoskeletal pain. So these things over the first few days should be very helpful for people who are experiencing these symptoms. Now, what are the red flags? What are the things, if you experience these, where you need to get concerned, you need to call your primary care doctor or call someone and start asking some more questions? So one of them is if your back pain has been going on for more than 6 weeks, if you have a personal history of cancer, if you've also been having fevers, sweats, or chills during the same period of time, if you've been losing weight without trying to, not that you've been on a crazy diet having 500 calories a day and you've lost 2 pounds, but an unexplained weight loss over the past few weeks. If you have a personal history of IV drug use and you have acute episode of back pain, that's more concerning. If you have any weakness in any specific muscles in your legs, so not that you feel kind of overall that you have a lot of pain, but you notice you try to stand on your toes or you try to move your feet and you notice some real weakness in those muscles. If you have numbness or tingling in your legs, and if you have any bowel or bladder dysfunction. So we always ask about incontinence. So that is, are you able to control your bowel and bladder? Have you ever had any episodes where you've gone and you didn't even know it? Those are the kind of things that you should talk to your doctor about. And then unremitting pain. So pain really that does not get better after these first 6 weeks. That's a time where you should be bringing it to the attention of, start by your primary care doctor to try and figure out what's going on. And there's a lot of different types of imaging of the spine that we get. And you're probably first time going to end up at your primary care doctor, and they may or may not order x-rays depending on exactly what type of symptoms you describe. And x-rays are actually very, very useful. As a spine surgeon, I get x-rays on almost all of my patients, even if they have an MRI. And the reason is that x-rays, you can see on the left, that's looking at you from the side, and the one on the right is looking at you from the front. X-rays are a great way at looking at the bones of the spine and looking at the alignment of the spine. So we can see big problems with alignment, we can see collapsed discs. There's actually a ton of information we can get on a very quick and easy scan that has very little radiation. And what you're looking at here, that's one of the vertebral bodies of the spine. That's what's indicated in blue, that outline, that box. And that's pointing to a disc space. So in patients who have collapsed discs, you'll see that at some levels those heights can be lower. A CT scan is another type of study that your doctor may or may not order, and this is basically like an X-ray on steroids. So it does have more radiation, but it allows us to look at the bone much more carefully. So a lot of times there can be some small fractures that we can miss on an X-ray. And so a CT scan, as you can see, you have a lot more definition specifically of the bone. And I think everyone in this audience can tell that there's a big difference between these two CT scans. So the one on the left is a normal scan, and the one on the right is someone that has a lot of degenerative changes of the spine. They've got collapse of those disc spaces. That black is air in the disc spaces. The increased white is the inflammation and sclerosis of the vertebral bodies. So these are all changes that are very consistent in someone that has, severe degenerative disease of the spine. And the CT scans also allow us to do these three-dimensional reconstructions that we sometimes get. An MRI, on the other hand, is a great study for allowing us to look at soft tissues. So it lets us look at the spinal cord itself, the nerve roots themselves. And what you can see here is, once again, looking at you from the side. So the belly is there, the back is there, and the feet are down there. This is the spinal cord in gray, and the white stuff that surrounds it is the spinal fluid. And we can slice the MRI like a loaf of bread. And once again, look here, this view here shows you the spinal fluid surrounding all the nerve roots, the bones in the back, the front, and then all the muscles as well. So an MRI is a great way to look at something like a herniated disc. You can see here, these are normal discs. This is a herniated disc right here, protruding backwards and impinging on the nerve roots. And you can see it also on this view right here. That is the disc coming out. So I mentioned at the beginning that a lot of back pain is nonspecific, but there are some very specific causes of lower back pain. And these are the cases where, as surgeons, we can actually help more when there's a specific thing underlying the back pain. So one of them is a disc herniation, like I mentioned, and I showed you an example of an MRI. And disc herniations actually usually don't just cause back pain, but leg pain, okay? So pain radiating down from your back all the way down the leg in a specific distribution. And many people call this sciatica. Technically, sciatica really only refers to one of the nerve roots, but people kind of use that term to refer to pain, which is lumbar radiculopathy pain, compression of a nerve root in the lower spine that leads to pain in the legs. I'm sure many of you have also heard the term spinal stenosis. So once again, incredibly common. If we got an MRI of every single person in this room, including myself, we would all have varying degrees of spinal stenosis, okay? So the question is really just, when is it actually causing problems? And you can have stenosis of the central spinal cord or canal itself, as well as the nerve roots as they exit at each level. And in older patients, one of the most common things we see is spinal stenosis in the center of the lower lumbar spine. And this is the shopping cart sign. So patients complain that they've got lower back and buttock pain. Their legs really ache, especially down the front of their thighs. When they go, and it gets worse when they walk. Maybe they walk 5-10 minutes. They lean forward on the shopping cart at Whole Foods, and they're much better. They sit down and relax, and they're better. So that is very, very typical for lumbar spinal stenosis. And then much less common, but also something that I treat and enjoy treating, is scoliosis or kyphosis. So scoliosis is a curvature in the plane as you're looking at me, so like this, whereas kyphosis is a curvature in the plane if I stand to the side like this. If I have a hunchback, that's referring to kyphosis. And a lot of times people have problems in both planes. Some of you may have also heard the term spondylolisthesis, okay? And really what that means is that when you look at the spine, and this is particularly well seen on an X-ray or a CT scan, you want to be able to draw a line clearly right here. you see at this point that this vertebrae is slightly in front of that. So that line, that curved line, is not in alignment. It's not in alignment. So sometimes, most of the times, this actually isn't a problem, but sometimes it can be a problem, and you can have motion, especially as you're moving your back, that can lead to significant back pain. Spinal infections, which you can see here, are also a problem that can occur in people that have history of infections of the bloodstream, IV drug use, or other situations that can lead to some very, very significant back pain. And then I'm going to talk about this quite a bit later as well, osteoporosis-related spine fractures. So you can see here the X-ray on the left, and we have the CT scan on the right for the same patient. And you notice how much easier it is to see the bone on that CT scan, so why it can be very helpful. And this right here is the compressed vertebrae in a patient that has pretty significant osteoporosis. And sometimes you don't even need to have a fall to end up with a compression fracture like this. And then, of course, there's also spinal cord injury. This is the neck. So this is the front of the neck, the back of the neck. And you can see that the problem is right there, where this patient had a devastating spinal cord injury and ended up paralyzed. So much less common, but one of the things that as spine surgeons we also treat. As well as neoplasms or tumors of the spine. Once again, much less common, but we do see some spine tumors, primary spine tumors, and then also tumors that metastasize from other areas like the breast, colon, or lung. So I went over a bunch of these specific causes of lower back pain, but as I started off at the beginning, really 90% of patients who present to their primary care doctor with back pain have nonspecific back pain, i.e. really none of these. And as I mentioned, back pain is more common in women. There have been several studies that show a higher prevalence, 10% of women versus 6.6% of men with severe lower back pain in a French study. Another study in Germany showed that the 7-day back day prevalence was also higher in women compared to men. But there are also a whole lot of other important risk factors for back pain, including higher body weight, older age, physical inactivity, smoking, unemployment, lower socioeconomic status, uncomfortable working positions, so people that have jobs that involve significant heavy labor or uncomfortable positions like operating. Spine surgeons actually have a lot of spine surgery themselves, and lifting weights. So why is back pain more common in women? The very simple answer is that there's not one specific reason. This is a little bit of hand waving, but one of the issues is that what we're really going to talk about is osteoporosis, but separate of osteoporosis, we do see back pain more in women. So women when they're pregnant obviously have back pain very frequently. Likely has to do with the distribution of, abdominal weight around the spine. There can also be perimenopausal weight gain, specifically around the abdomen in women as we get older, that may contribute to this. And then some people, really do talk to me and say that they have fluctuations in their pain sensitivity based on their menstrual cycle. And if you do have an underlying chronic lower back issue, that can exacerbate it. So what are our treatment options for lower back pain? And this goes back again, this is applicable to men as well. Okay, so the first thing is assurance and education. So 90% of patients with acute lower back pain will have stopped consulting their doctor within 3 months. And only 5% of people that have an acute episode where they feel like they can't get out of bed, the world is ending, will really develop chronic lower back pain and a permanent disability as a result of this. So one of the first few things is just educating patients that this is going to be all right. And then talking about good posture, work ergonomics, correct sitting and lifting positions. So a lot of us these days have desk jobs that involve staring at a computer for very long periods of time. So one of the very simple things you can do is place your computer screen higher up so that you're not looking down like this with your neck in a kyphotic position, but rather looking up at your computer screen. For me personally, that's a big source of neck pain because when I operate like this with the heavy light and loops on, and I finish a 12-hour case and my neck is killing me, right? So these are, there's certain things obviously that you can change about your work or your situation and other things that you cannot, but these are things that you should be aware of. Physical therapy is one of the first-line conservative treatments for any type of lower back pain that's lasting more than a few weeks. And what that really involves is core strengthening. So if you strengthen the muscles around your spine, that relieves the pressure on the spine and can greatly improve people's outcomes. So specifically Pilates, yoga, core strengthening, and also there's been some publications showing that aquatherapy works really well, because I have patients that say, I can't walk more than 5 minutes without severe pain, but you put them in the water and you take that pressure off of them and they're able to participate in a full 30 or 60-minute session, and so that can be really, really good for some patients. I don't necessarily recommend this, but this is something that I did recently, which is a thing. Okay, so yoga, good. Goat yoga, maybe not so much, but they really like the tabletop position and they crawl on you, which is really quite fun. Other things other than physical therapy include acupuncture. Some people may or may not have tried inversion tables. That can be helpful for the pain that I talked about. That's the sciatic type pain, where you have pain from a compression of a nerve root in the spine that radiates down into the legs. And then many people, I'm aware, see chiropractors, and if people have specific questions about that, we can maybe address it in the question and answer session. Weight control is one of the most important lifestyle modifications that I tell people who have chronic lower back pain. So we know that obese patients have higher rates of lower back pain compared to non-overweight patients. And one interesting study, actually, they had morbidly obese patients who underwent bariatric surgery for weight loss, and they actually saw that their back and leg pain improved and they had increased disc height. Okay, so essentially this is just when you have more body weight, especially more body weight in the abdominal region on the spine, that contributes to pain. Smoking is also linked with worsened rates of lower back pain and spine disease in general. So we see higher rates of lower back pain in people who smoke on a daily basis compared to those who don't. It's associated with disc disease, and when patients smoke and have spinal surgery, they do much worse. They have worse outcomes, higher complication rates, and more pain. And so for patients who are undergoing elective spine surgery, I and most of my colleagues at this point will ask patients to quit smoking, and a lot of times nicotine test them in order to ensure that they really have the best chance of having a good recovery from a spine surgery and doing well, as opposed to having complications and not having good pain relief. And there's not a ton of data for this. This is really just one study. But at the same time, I don't necessarily think it's harmful. And people are taking omega-3 fatty acids for lots of reasons these days. And they are anti-inflammatory. And so they may help reduce some non-specific neck and back pain. And there was one study of 250 patients with back and neck pain who took fish oil, and a good portion of them were satisfied with their pain improvement. So it may be a very simple, cheap thing that you may already be doing that might help. And bone health is very, very important. So you can see the osteoporotic bone, which basically just means bone that is weakened, on the right. And you can see, unfortunately, as women, so women are more prone to osteoporosis, and as we get older, we're more prone to this as well. And this can be a big problem, both in terms of contributing to back pain and also contributing to us doing poorly when we do have spine surgery to treat our back pain. So we know osteoporosis is really common. 34 million people in the United States have low bone mass, and 50% of women over the age of 50 will suffer an osteoporosis-related fracture in their lifetimes. Each year, the risk of suffering a fracture from osteoporosis is greater than the combined risk of suffering a heart attack, stroke, and breast cancer in women. And when you do have an osteoporotic fracture, especially in your hip and spine, what this is showing right here is that you have an 8 more than 8 times greater risk of death if you have a spine-related osteoporotic fracture than if you had not had that fracture in your spine. So it's not a good thing, especially not a good thing to have when you're older and you have a lot of medical issues going on. And so there's a lot of modifiable risk factors for osteoporosis and non-modifiable ones. So we can't prevent getting older, we can't prevent our race, our sex, we can't prevent whether or not our mother or grandmother had osteoporosis, and we can't prevent the fact that we're all going to become postmenopausal at some point. But the things we can change, we can quit smoking if we smoke. Steroids. So a lot of people are on steroids for various reasons, whether it's COPD and asthma, arthritis, those can greatly weaken the bone. So I'm not saying that you shouldn't be on them if you have to be on them for medical reasons, but if you are, you need to make sure you're getting screened for osteoporosis because you may have much weaker bone than you know. There are other medications as well, like anticonvulsants that people take from seizures that can impact bone quality. Significant alcohol use, including wine drinking several times a week, can also contribute to osteoporosis. Being inactive, being too thin. Okay, so I told you you don't want to weigh too much. You don't want to be too thin either, because that can also predispose you to osteoporosis. And being undernourished. So osteoporosis is diagnosed with something called a DEXA scan. And this is essentially just a special x-ray where they compare your bone quality to either people who are your age or healthy 30-year-olds. And they come up with something called a T-score. So if your T-score is less than negative 1.5, any positive number, that's great. Okay, if your T-score is between negative 1.5 and negative 2.5, that's osteopenia. So that means that your bone is already weak, and you definitely should be talking to your primary care doctor or an endocrinologist about getting treatment for that. And if it's less than negative 2.5, that's osteoporosis, and 100% you should be doing something about it. The current guidelines are that all healthy women over age 65 should get a DEXA screening. And you should be considering this even if you're younger, if you have a family history, you have a particularly low body weight, excessive drinking, you have a history of rheumatoid arthritis, for example, you've been on chronic steroids for any long period of time, you smoke, or if you have a fracture in any part of your body that's really not explained. You didn't have a fall, you had a very, very minor trip, and that led to a significant fracture. I think for men it is age 75, but I would check with your primary care doctor about that. It's older for men in terms of when you should get screening. Okay? And it's not done as frequently in men. So what can you do to optimize your bone health? Well, some of the very basic things that you can do even when you have great bone health and starting from a young age is calcium and vitamin D. Weight-bearing exercise and strengthening. There's, pros and cons, obviously, and so this is something to discuss with your primary care doctor, but hormone replacement therapy can be considered after menopause, but there's obviously some disadvantages to that as well. There are the main medications that actually treat osteoporosis fall into a few different classes. One of them is the bisphosphonates, and these are medications that inhibit the cells that actually break down bone. So they're not going to help you build bone, but they're going to help the deterioration and the breakdown of bone that happens as we get older. And some of these are pills, some of them are injections. There's a bunch of different ones, but I'm sure you're very familiar with some of these names, including Fosamax, Actonel, Boniva, Reclast. There's a lot of ads on television for them. Prolia is another one that can sometimes be really nice because it's an injection only a couple times a year, so you don't have to remember to take a pill every day, and that also works on osteoclasts. The only medications that build bone, however, are these medications that are daily injections, and the main one right now that's on the market is teriparatide or Forteo. Tymlos is even newer. So in spine in particular, When I have patients who I'm considering doing a very big spinal fusion on, I will, and more than 1 or 2 levels, I will screen all my patients with a DEXA scan. And if they have osteopenia or osteoporosis, I will ideally try to get them on teriparatide or Forteo for a few months before surgery and as much as a year after surgery to strengthen the bone. What we've found in our research is that improves when we're putting in these screws and rods and asking your bone to fuse. We have better rates of the bone actually fusing, screws not pulling out, screws not breaking, if we treat the osteoporosis first up front and then afterwards as well. But I will say that it is very challenging. This particular medication is super expensive and not covered by most insurances, and so it can be a really big pain to get people on it. And also a very important thing to know is if you have a personal history of cancer, it is contraindicated. So if you're thinking about talking to your endocrinologist, you can only get a prescription for this from an endocrinologist. I can't write it for you. Your primary care doctor won't write it. That is something important to keep in mind. So what kind of, other than the physical therapy, medications that we talked about, and other lifestyle modifications, when we start getting into interventions, what can we do to help treat your back pain? So we've got a bunch of minimally invasive procedures, and these are injections that are usually done by pain management doctors. These people can be anesthesiologists in training, they can be physiatrists, which means that they're people who focus in physical medicine and rehab, and occasionally sometimes neurosurgeons or orthopedic surgeons do them, but most of us don't because most of us focus on just the open surgery. And it's important, there actually are a lot of different types of injections. This is one of the things that I notice the most when patients come to me. They say, oh yeah, I got an injection into the back. Well, there's a lot of different types of injections, and how what type of injection you had can really affect how you respond to it and can tell us a lot of information in terms of what's actually causing your back or your leg pain. So there are epidural steroid injections. What this is they go in with a needle, usually with fluoroscopy guidance. So that means that they're getting an x-ray to see where they are. And they inject some local numbing medication and oftentimes a steroid in the area around the nerve roots. There's also something called a facet block, and that's a totally different place where they go in. They go in on the side where you have the joints of the bone, and there are some smaller nerves that innervate that joint. And so that's a totally different type of procedure that they can do to help with a different type of pain. And then they can also do what's called a selective nerve root block, where that's also going in more from the side. And that's saying, we've decided L3 is really your problem, and we are going to do a selective nerve root to target and put numbing medication and steroid around that specific nerve root and see if your pain gets better. I showed you that picture of the lady that had the really bad osteoporotic fracture where her vertebral body was completely collapsed. When that happens in the acute setting, a lot of times you might be a candidate for something called a kyphoplasty or a vertebroplasty, which once again is a procedure, not an open surgery, where you essentially go in with a needle, inflate a balloon, and fill that with some cement to increase the height of that vertebral body that's collapsed and help with pain control. And here you can see an example. On the left is an MRI of someone that has a collapsed vertebral body. Where that arrow is, you can see that it's much smaller than what a normal vertebrae should look like. And then on the right, you can see they've injected the needle, they've inflated the balloon, and then injected cement into that vertebral body. And that's really just to help with pain control. So I'm a surgeon. What about spine surgery? So I fully realize that we get a bad rep out there, and that's because there are, a lot of different types of spine surgery, but they really need to be done for the correct reason. So the most important thing when I see a patient is I first want to figure out what's causing their back pain, what exactly is the source of their pain. Because if we don't know what the source of their pain is, then we're not going to effectively treat it. And there's so many different things, as you've seen today, talking to you, that can really contribute to the pain. So when you choose an appropriate patient, Spine surgery can be highly successful when it's executed on the right patient, but it's critical that we diagnose correctly and really know what's causing the patient's pain, because risks are high, complications can be devastating, and then when you get into a sequence of having several failed spine surgeries in a row, and I'm sure many of you have some friends who've had multiple spine surgeries or spinal fusion surgeries and done very poorly, then they end up, on my doorstep and we're doing surgery for the 5th time around. It's a much more challenging surgery and a much bigger deal. So one of the things that we do, I mentioned spondylolisthesis, and you can see on the far left that X-ray has one of the bones, one of the vertebrae that's moving relative to the other one. So that's a type of problem that you can only fix with a fusion surgery. You have to immobilize the spine in order to fix that movement that's contributing to the pain. And to do that, we put in screws and rods. There are a lot of different types of them, and there are a lot of different ways that we can go in from the spine. And so it's a little bit of an alphabet soup. We've got A-lift, T-lift, P-lift, O-lift, X-lift, literally going in from the front of the spine, going in from the side, going in from the back, going in between the front and the back, the oblique lateral interbody fusion. All of these are different ways that we go in, remove a disc, put some sort of cage or bone in between to help promote a fusion, and then usually also put in screws and rods to stabilize the spine. But there are a lot of different reasons why one particular type of approach may be better than another. So it's really important that you talk to your surgeon about what approach they're doing, why they think that one's the right one for you, and what some of the specific risks and benefits are specifically of that particular approach. So there are, you get one thing from this, it should be that there are so many different types of spinal fusions. They are not all the same, and it's really, really important to get more information about what kind of spinal fusion you're having and why. This is an example of a lady that I treated this past year who had really, really severe back and leg pain from, you can see here on that scan that L5 vertebral body is almost entirely in front of her S1 vertebral body. And so this was a very challenging case to fix, but we're able to reduce her back and get her into alignment. And you can see here, the only way to fix that is to put in screws and rods and bring her back into alignment. And she did very well. The other cases where we do spinal fusion cases are in scoliosis cases. So here's an example of a gentleman I treated this past year, who you can see on the far left, that's an X-ray looking at him from the front, and he's got that crazy curve, and you can see the CT scan here, and there's a ton of degenerative changes of all the discs, air, arthritic changes, and he underwent a spinal fusion to correct that. And then we also, so one of the things that I specialize in and really enjoy doing is revision cases. So this is an example of a lady who had had multiple spinal surgeries. I can't remember the number, 4 or 5 on the far left. And she developed something called proximal junctional kyphosis. So essentially she went from being straight, you can see her, to being like this. And that's as a result of falling over at the top of her construct. And so the only way to fix this type of problem is to go in, take out some wedges of bone, and put in screws and rods to straighten her out. So you can see how she looks there on the far right, and she's a good several inches taller. And I mentioned scoliosis in one plane, kyphosis in the other plane, and then we have a lot of patients who have problems in both planes, okay? So this is so that you can see kind of what this patient looked like. And unfortunately, she had scoliosis from a young age when she was an adolescent. At the time, she was treated with Harrington rods, which were these rods that were put in. She had multiple spinal surgeries, and you can see she still has a really bad scoliosis, and she's also leaned forward and shorter. And so we addressed not the entire extent of the scoliosis at this time. It's very likely she'll need that in the future, but really the main issue she was having was, standing forward and stooped over like this. So that's another type of case where spinal fusion is very useful. So we talked a bit about back pain. Neck pain is also very common, although a little bit less common. And overall, about 6 to 39% of people will experience neck pain over the course of their lifetime. The highest incidence is between the ages of 45 and 64, so I think we've got that age demographic right here tonight. And the important thing is that if you do start getting imaging on everyone in this room, 75%, most of you are going to have some evidence on x-rays or MRI of some degenerative changes of the spine. Like back pain, neck pain is more common in women, and you can see that this is true across all age groups. And it's also more common in certain races. There's a higher rate of neck pain in patients with no high school diploma. It's more frequent in the Western US, don't ask me why. But other risk factors include smoking, depression, people who work in awkward or sustained postures, low income, people who are widowed or separated, and people who have more medical comorbidities. So just like the sciatic pain that we talked about in the back, where you can get a disc herniation that compresses a nerve root and leads to pain going down your leg, the same thing can happen in the neck, and you can get what we call cervical radiculopathy, from a little disc herniation from a disc in the neck that compresses one of the nerve roots that goes out to your arm. And sometimes it can be associated with numbness, weakness, and this may be caused by a disc herniation, a decreased height of a disc, or just some degenerative changes and arthritic changes of the spine that we all get as we get older. And there's also another thing which is more severe than the cervical radiculopathy, which is a term we call cervical myelopathy. So instead of compressing those nerve roots that come out on the side, you can get changes in your spine that compress the spinal cord itself. And a lot of times these patients actually don't necessarily have pain, but they notice that they start having worsening numbness, tingling in their hands, difficulty buttoning buttons, opening jars, gait instability, urinary incontinence. So those are all things that kind of happen progressively over time and would definitely be a reason for it to cause alarm and bring attention to your primary care doctor. Similarly to back pain, we have a lot of treatment options for neck pain, starting with assurance and education, physical therapy. One of the things that can be very helpful for patients that have cervical radiculopathy, which is if you have neck pain from a herniated disc that radiates into your arm, is something called traction that you can either do with a physical therapist or at home, and I can talk more about that in the Q&A if you guys are interested. Similar lifestyle modifications, including quitting smoking, making sure you have good bone health, non-steroidal anti-inflammatory medications that you can take over the counter, and then just like with back pain, your primary care doctor may provide you a short course of steroids. They may provide medications that help specifically for nerve type of pain. These have different names, including gabapentin, Neurontin, Lyrica. They may prescribe you with a muscle relaxant if they think your pain is kind of more from a pulled muscle, and there's a lot of different medications for that. Some of them include Flexeril, Baclofen, and then there obviously are the opiates, which we won't talk about today because that's a whole nother topic of conversation, but one in general that it's good to minimize long-term use of opiates for a variety of their bad side effects. And just like in the back, there's a bunch of minimally invasive procedures that you can do for back and arm pain. And these things here are similar injections that are done once again by the pain management doctors. So the epidural steroid injections, they can do trigger point injections where they literally point to one place and they say right there at that one point in my shoulder blade is where it hurts. And they literally just inject some numbing medication into there and see if it helps. And then nerve root blocks, well, they'll target a specific nerve. They'll say, okay, you've got pain that's radiating right into here, into this finger. I think that's C6, so I'm going to do an injection around that. But it's very, very important, even more so than in the lumbar spine. In the cervical spine, everything is smaller, everything is more delicate, okay? A problem, a complication from an injection in the cervical spine could lead to paralysis in the very worst case. So it's really important that while these are procedures, they're not open surgeries. It's just a minor thing. You go home the same day. It's really important that you go to someone good, especially for the neck injections, because that's very high real estate there. And so that is critical. And then we've got our surgical options. So just like in the lumbar spine, where we made you fusions for certain procedures, one of the most common spine surgeries done in the United States, I bet you most people here know someone who's had one. It's called an ACDF. We go in, take out a little bit of the disc, replace it with a piece of bone, and put a plate and screws in. Some patients, including younger patients, those who don't have significant arthritic changes of their spine, may be a candidate for a motion-preserving surgery in the neck. So this is one of the procedures that I do, and for the right patients, it's awesome. We go in, we take out the disc. Instead of putting in a piece of bone and a plate and fusing them, you put in a disc replacement. And there's some very good data that shows that this works very well in appropriately selected patients. The reality, unfortunately, is that most people aren't candidates for this, but if you are a candidate for this type of procedure, it can be a great option. Or we can just go in from the back, if it's just one nerve root that's causing a problem, drill out a little bit of bone and help alleviate some of the pain without doing any fusions. And then, of course, we've got our fusion options. This is an example of a patient I treated this past year who had a spinal cord injury. He was in the Bahamas. He fell off of a scooter. He woke up. He was paralyzed. It took him several days to get transferred to Hopkins, where I was working at that time. And what you can see here is that his spinal cord is totally crushed. And so the only way to fix this is with the surgery where you go in, decompress the spine, and put in screws and rods. And so he ended up doing really well. The recovery from this is a long process. Unfortunately, the videos aren't working, but one of the really nice things was that my office happened to be right next to the inpatient rehab at Hopkins, so I could just pop my head over every once in a while. So he came in totally paralyzed. About 5 weeks later, he was using this special walker, which is an upright walker, and then 7 weeks later, right before he went back, he was walking, and it was awesome to see him. So just in the last couple minutes, because I want to leave time for questions, a little bit about the future of spine surgery and some of the latest techniques that we're using now here at Stanford and some of the things that my colleagues and I do. So minimally invasive spine surgery, I'm sure you've read a ton about this. I'm sure everyone has seen the Laser Spine Institute billboards with the supermodel in the bikini with a Band-Aid. She looks great. She's on the beach. There are a lot of different ways of defining what quote unquote minimally invasive spine surgery is. But essentially what it means is trying to minimize the amount of blood loss and muscle retraction. So sometimes what this means, and you can see this on the left, is that you do a laminectomy or a decompression of the spine going through a tube. You can do minimally invasive fusions. So that's what's shown here in the middle, where all of these screws are put in with different stab incisions. It's a minimally invasive fusion to try to decrease the amount of blood loss. And these are all things that I do. Keep in mind, though, that while minimally invasive surgery does usually tend to have smaller incisions, it can end up being a little bit of a train track, especially if you have some of the larger ones. So. Motion-preserving spine surgery is also really good in appropriately selected patients. And unfortunately, most patients aren't good candidates for this, but this is like the cervical disc replacement that I mentioned, which is a great surgery for the right patient. And then this is something that I do routinely in my spinal fusion surgeries, but we use image-guided spine surgery. So this has been the standard of care in brain and cranial surgery for many, many years. And so there are a lot of technologies that allow us to either get a preoperative scan and register or an intraoperative CT scan and use instruments so that we ensure that we are putting in our screws into the correct places. And then Nora mentioned this, but robots are also on the scene. Cool, sexy, new toy. My mentor at Hopkins invented the Excelsius GPS, which is it's the latest spine robot to come out onto the market. And so we did the first case with that back in October of 2017. It was a big ordeal. There were lots of people there. But essentially what it enables you to do is it enables you to put in navigated screws in the spine. So take-home messages: low back pain, extremely common, but can be very complicated to treat. Surgery is simply another way to manage back pain that should be used as a last resort option. Staying active and focusing on low-impact aerobic activities can help maintain long-term back health. Osteoporosis is an extremely common disease of aging women, and osteoporotic spinal fractures put patients at increased risk of death. And so prevention is the best treatment. Surgery is used selectively for spinal fractures due to osteoporosis and has significant associated risks. And then finally, regarding neck pain, it's less common than back pain, but still very prevalent. Like back pain, there are multiple conservative treatments that should be tried before surgical intervention. And there are a lot of new surgical approaches, including minimally invasive spine surgery, motion-preserving spine surgery, computer-navigated and robotic solutions for both neck and back surgery. Thank you very much. Okay, so I'll take any questions.
So what is the medicine you can use for neck pain?
So her question was, what is the medicine you can use for neck pain? Do you mean if you just start having that you have some chronic neck pain?
Yes, at times.
Okay, so probably one of the first things I would take is just an over-the-counter ibuprofen or Aleve or naproxen, okay? Those are all available at your CVS or Walgreens, and those are medications that are non-steroidal anti-inflammatories. So those are the best first choice.
And what were you talking about traction at home?
Traction. So this is for pain that radiates from your neck into your arm, okay? And that is, so when that is a true cervical radiculopathy, that's usually caused by compression of the nerve root as it exits the cervical spine and goes out. And so there are home traction devices. You can go, there's one called the Saunders cervical traction device. I don't have any, I do not get any royalties from them or anything like that. But essentially what it does is provide a little bit of distraction this way, okay? And so that opens up the space around the nerve root and can alleviate some people's symptoms. So it can be very effective when done for the appropriate reason, ensuring that you don't have any severe stenosis or other things that would contraindicate it. And the most important thing is that if that is worsening your pain, you should stop right away. Okay? Of course.
In the cervical radiculopathy, can you have the numbness or the pain in the hand without having pain in the neck?
Yes, so his question was, in the cervical radiculopathy, can you have numbness and tingling in the hand without having pain in the neck? Yes, you definitely can. Yes.
Thank you so much, doctor. It was very good to hear all the background behind this. My question is, my mom has had back pain for about 4 years. And recently when we visited a chiropractor who did an x-ray, he said that she had potentially subluxation. I didn't hear that word come up here. I wanted to get a little bit better understanding of that.
Okay, great. So the question, just to repeat, was that her mom has had back pain for 4 years, and she saw a chiropractor who got an x-ray that mentioned the term subluxation, and she wanted to know what that means. So with the subluxation, most likely what he or she is referring to is like the spondylolisthesis that I mentioned, so that one of the bones is moving relative to the other or not appropriately in a line. And so for that, one of my main recommendations would be, one, that she should get something called flexion and extension x-rays, which means bending as far forward and extending as far backwards to see if that subluxation that he's talking about, if that spondylolisthesis moves, okay? If you do see movement when you're flexing and extending your back, then that could be a sign, that there's a problem that could potentially be treated surgically. If it's not moving, then it's much less likely to be amenable to surgical treatment. So that's one of the first things that you can do. But I think it would definitely be reasonable to ask for a referral to a spine surgeon if that is something that the chiropractor has told your mom. Yes.
Mine is about what he was asking about. I recently went to a chiropractor to have a back rib put into place. And in doing that, he did something with my neck, which left me with a lot of neck pain, and pain especially in this finger. And he said that would go away, that somehow it would go away as soon as the pain in my neck had gone away. I don't know what he did, and I've never had anything like that, and I didn't come into the office like that, but it's still there after more than 2 months, and I just wanted a next step, and I like to take care of things naturally rather than surgically, so what can I do?
So the question was that she went into a chiropractor and had some manipulation in her back as well as her neck. And this was 2 months ago when she had the manipulation of the neck. Since then, she's had new pain in the neck, and specifically numbness, tingling, and pain as well, and pain into her index finger on her left arm. What should she do? So it sounds very classic for a cervical radiculopathy. Okay, so, it might have been a little bit of a twisting motion that aggravated a tiny little disc or a little bit of degeneration that you have there. So as long as things are constant and not getting significantly worse, one of the first things you can get is get an MRI of the neck, just to make sure that there's nothing super alarming. Okay, then after that, when I see patients that have cervical radiculopathy, my recommendations are, everyone comes to me with an MRI, so that's kind of the baseline. As long as there's nothing super alarming on it, non-steroidal anti-inflammatories, okay? Sometimes I recommend a medication called gabapentin or Neurontin, which is a nerve pain medication. It's not an opiate, it's not addictive, and that is specifically to help with that radiating pain into the finger. It doesn't help with neck pain or things like that. That being said, I would say, realistically, maybe it works 30–40% of the time. But for the patients that it works, they're a wonder. They say, wow, gabapentin's a miracle drug. That's great. The rest of them say, yeah, I really didn't do anything, and it made me feel really tired. And so I say, okay, stop taking it. Cervical traction. But once again, I would be very cautious, especially since you had this experience after the chiropractor. Can be helpful for cervical radiculopathy and physical therapy. So those are kind of the first things. But given that it's been going on for 2 months, I would recommend just getting an MRI just to make sure there's nothing horrible. As long as it's just a tiny disc herniation, then all of these things would be appropriate next steps.
Okay, thank you.
Of course. Yes.
I'd be interested in your comments on things that many of us do as a first resort, like, say, replacing a pillow with something that's marketed as being really good for the neck, or getting seat cushions or a lumbar cushion in our car if we don't have a really great driver's seat. Are those just stopgap measures that are perhaps going to keep us from having as much pain? Is there a downside to using those? They're obviously not like the kinds of treatments and interventions you've been talking about, but they're quick and they're cheap.
Yep. Great question. So her question, just to simplify, is what about a lot of the things that we do for back or neck pain, like getting a special pillow, lumbar support, things like that? Is there any harm to doing this? Is it just a stopgap? And the answer is that there's no harm and those things are great. So as I said, because 90% of back or neck pain is nonspecific, i.e. it's not any of these specific reasons, and it should not be treated with surgery at any stage. The main, the types of things you suggest are great for nonspecific back pain. So in general, if you find, for example, that you know, you have a certain mattress and you sleep on it, and at home you seem to always wake up with lower back pain. This is my husband right now. We just went away on a trip, and he was like, I don't have any back pain. And we came back a few days later, and he's like, I think we need a new mattress. And I'm like, you know, try it. You know, one of these last talks, someone actually said, what's the right mattress? I do not know, okay? But in general, slightly firm, but whatever works for you. So if those pillows work for you, if that lumbar support works for you, great. Yes.
So in the same vein, do you have any comments about these things like massages and chiropractor, because those are not medical doctors doing it?
So his question is, do I have any comments on massages and chiropractors? So first of all, massages. Full disclosure, I get Thai massages about once a month, and I get really, really, really intense Thai massages. You know, the ones where they step on your back. So I'm not recommending those. But in general, I think massage is fine if for the type of pain that most people have. You know, if you do have severe stenosis or something like that, it's probably not great to have, you know, the Thai masseuse walking on your back, but take that with a grain of salt, as I said, because I get them myself. Chiropractors, so that's a little bit of a mixed bag. And in general, in my field, kind of in my training, I was sort of raised, so to speak, with a little bit of an anti-chiropractor take, which is what you'll hear from most surgeons. The problem was that in my neurosurgery training, I did take care of a couple of patients that had a stroke in the brain from a neck manipulation from a chiropractor that led to a dissection of the vertebral artery. And one of those patients ended up passing away. So that is a very, very rare complication, but it is one. That being said, I recently went out to a chiropractor here locally because, you know, most of my patients have seen chiropractors, and I actually didn't really know what they do, you know, like their training is so different from ours. The terms that they use are totally different from ours. And so I was like, okay, I just want to learn what are all the things that you do. So I think a lot of the things that they do are very reasonable. You know, a lot of them focus on physical therapy, and they've got stretching. They've got, I mean, I don't know if these, you know, if the stimulation, the electrical stim does anything, or the percussion, but those aren't particularly harmful. So if they make you feel better, great. I would be very cautious when they do those manipulations, especially in the neck. That's where I get very worried. But, you know, what I can say is that I definitely have a ton of patients that see them. Sometimes they do provide relief. I worry about the neck manipulations. And if there are any red flag symptoms, you need to get some imaging before you subject yourself to treatments by a chiropractor to make sure that there's nothing that is not going to be worsened by their treatments.
And can you say something about acupuncture or acupressure in the same vein?
His question was, what about acupuncture or acupressure? So I don't do that. You know, I'm trained in Western medicine. That being said, I personally have tried acupuncture. There is some data that it is very effective, and there's nothing harmful about it. So patients ask me, and I say if they want to do acupuncture, I say go for it. If it helps you, wonderful.
How do you feel about the use of a TENS unit for back pain?
The question was, how do I feel about the use of a TENS unit? There's no reason not to try it. Quite honestly, the efficacy is probably not great, but similar to, for example, acupuncture or something, I view it, or taking fish oil, I view it as something that's not harmful, and if it does benefit you, that's great. And a lot of my patients have tried all of these things: chiropractor, you know, TENS, braces, pillows, mattresses, physical therapy before they come to see me. So it's not harmful. Yes.
How common is adjacent segment disease?
The question is, how common is adjacent segment disease? So for those of you who aren't aware of what that is, so basically what that means is that when we do a spinal fusion surgery, one of the most common complications is adjacent segment disease, which means that the level of the spine above or below develops degeneration and can end up needing more spine surgery or like an extension of the fusion. So that depends on the type of surgery that you have. And so yeah, I would say it depends on the type of surgery that you have. There's a lot of things that we do to try to prevent it. One of the issues, so for example, taking a simple surgery like an ACDF, the anterior cervical discectomy and fusion surgery, which is the most common spine surgery done in the United States. There's certain technical things that we can do to try to prevent adjacent segment disease. One of the reasons why the cervical disc replacement has become very popular is because it actually has lower rates of adjacent segment disease. What happens is that when you fuse a segment of the spine, that spine is no longer mobile. So it puts unnatural forces on the spine above and below, and that's what causes adjacent segment disease. So the concept behind motion preserving surgery is the spine is still moving mostly normally, so that is decreased. That being said, it still happens despite all these things that we do to try to prevent it. Yes.
Couple of questions. In relation to the fish oil, does flaxseed oil work? Do you know? Is there any study on that one?
So she asked, she's following up on the fish oil, and she says, does flax oil work? I'm not familiar with a study on it.
The main question I have is about the trigger point
Yes.
injection. I was scheduled, I saw the pain clinic in February. I started having pain last October, my neck going down my arm and numbing and tingling. Primary care, we ended up, he said if I wait to get you into a neurologist to get the nerve conductivity test, it might take a while, so he did it. I did it through a chiropractor that he knew that was trained in it. Came up, results from that said I had carpal tunnel.
Okay.
But I then was waiting to get in for cancellation at the pain clinic and saw them. They did an x-ray. Before the x-ray, I saw the pain psychologist. It was a medical evaluation appointment, and came away from that saying we could try the trigger point. It was scheduled for a week ago. I had to cancel. Now I'll be out of the country for a month. It's scheduled for May. Is it important that I see them again before I do the trigger point to make sure that we've got the actual point? I've started therapy for this part, but I haven't been able to start for the shoulder. But I am doing some of the recommended, and now since you said in paralysis, I'm like, ah. So.
Okay, so that was a long question, so I'm not going to repeat it. But have you ever had an MRI of your neck?
I have not had an MRI of my neck. I've had the MRI of this part of me because I am a breast cancer survivor.
Okay. So I think the next step would be to get an MRI of your neck. Okay, that's the next step. Because yeah, and a lot of times these things, so it's very common to have an EMG that's equivocal, that shows that someone may have a cervical radiculopathy and a mild or moderate carpal tunnel. I mean, that's a super common thing. So kind of teasing out, what's going on. But if you're still having neck pain, pain that's radiating down your arm, I think it's worth...
And all that.
And I think it's very worthwhile to get an MRI of the neck, especially because I would want your injection to be targeted at the place that you have the pain. Okay, so like if it's a disc herniation causing a C6 radiculopathy, they shouldn't do a trigger point, they should do an epidural steroid injection at C6. So that's the next step.
Okay,
Yes.
I see older people who are really hunched over, and I saw an image on the screen. Are these people candidates for your type of surgery?
So the question is that he sees people who are very hunched over. Are they candidates for this type of surgery? And the answer to that is that it really depends. Okay, so I have to see every patient. I don't have a specific age cutoff for when or when I will or won't operate. And that's because there are 80-year-olds who run marathons, and there are 50-year-olds who have severe heart failure and are on oxygen who wouldn't even be able to have a 1-hour spine surgery safely. So it depends on the patient. It depends on what their other medical comorbidities are. It depends on what they've done so far. How much is this impacting their lives? And I'm thinking very specifically of a patient I saw in clinic just yesterday. Horrible kyphoscoliosis. I mean, completely leaning over to the side. But, you know, one needs to get optimized in terms of her bone health. So I've sent her to endocrinology. She's going to go on that medication for at least 6 months before we'd consider doing anything. 2, needs to quit smoking. And 3, need to be, you know, convinced that they're medically stable enough and healthy enough to handle a big surgery, but that, you know, you have to be willing to weigh the risks and benefits. So usually I like that they've done physical therapy, that, you know, that they've tried other things to help their pain. Purely just for appearances is not a good enough reason to put someone through a huge spinal surgery like that, because it is a really big deal. You know, those surgeries I showed you, they take 10 hours. Patients are in the hospital for 5 to 7 days, and then they go to rehab after that. It's a long recovery process. So it needs to be in a patient that I think can handle it medically, safely, and that's really tried all other options to treat their debilitating pain that's really impacting their quality of life. Oh, okay. Sorry about that. Which one?
That lady.
The hat and the hat?
Yep.
Yes. Sorry about that.
I know, way in the back. 2 real quick questions. One is, what does it mean if you can hear your neck, you know, a scraping noise when you turn your neck? Because that's something that should be looked into. And I hear a constant scrape. If I turn, you can't hear it now because we're in a big room. But if I'm, you know, quiet, I can hear that scraping noise.
So her first question was, if you can hear a clicking or a scraping of your neck, is that a bad thing? Should I look into that? I would say that that's very common. It sounds like you probably have a little bit of arthritis of your neck. As long as you don't have severe pain, any weakness, numbness, tingling, I wouldn't necessarily do anything further.
The other question is, if you've had compression fractures and due to osteoporosis, and you had a perfectly straight spine up until then, and you were 5'6", and now you're 5'2.5". What should you be sleeping somehow? Why would you still be allowed to sleep on your side when it creates? It makes a spine curve while you're sleeping. That's 8 hours of. Is that bad?
So her question is, if you've had a couple of osteoporosis-related fractures that have made you go from 5'6" to 5'2", is it a problem if you're sleeping on your side at night? So, you know, it's really hard to change how people sleep, and honestly, I don't necessarily think that has a big. Yeah, I mean. So what are the things that you can do in your situation? So the things that you can do are, 1, you can make sure that you've spoken with your primary care doctor and endocrinologist and are on the best medication to strengthen your bones, okay? In the acute setting, when someone has an acute fracture, compression fracture with severe pain, sometimes I'll recommend a brace. Okay, but only in the acute setting. I mean, if these fractures happened years ago and you're doing fine and it's just your posture, we don't really recommend braces. Okay, and then in the
but they said don't wear them at night.
Yeah, I mean, yeah, you can. I mean, the other thing, you know, is the kyphoplasty or the vertebroplasty, but once again, that's in the acute setting. Okay, yes.
Thank you very much.
Okay, great.
Thanks very much.